I basically have lots of different hats I wear, but I'm going to talk primarily about gram-negative bloodstream infections. And I'll present to you some national data, which was kindly lent to me by Susan Hopkins, and then a bit more of our regional data. Okay, so the journey in terms of healthcare-associated infections has been a long one. And for those of you with longer memories than I will know that this whole process of discussion started way back at the turn of the millennium, really, sort of 1999-2000. And there was a series of documents that came out from the DOH at that time, things like cleaner hospitals and clean, safe care. Then the NAO made a comment about the management of HCIs in NHS trusts. And then in 2002, there was the Getting Ahead of the Curve, which was a major step change in the way that NHS England and DOH looked at managing hospital-acquired infections. Then there was the Winning Ways document in 2003, Saving Lives, the Health Act in 2006, and it goes on. So the history really here is that in March of 2016, there was an expert advisory group within RHI which recommended that the gram-negative bloodstream infection rate should be halved, and this ambition was then thought to be put in, signposted by 2020. And certainly when there was a press statement of the G7 back in 2016 from David Cameron's office, there was a big debate about reducing gram-negative infections and how that could be achieved. As you are all aware, in September of 2016, the CCG quality premium came into effect, and in 2016, the end of 2016, Ruth May, the Director of Nursing, then was appointed to lead the national strategy. And certainly through 2016, there was a consensus across the UK in terms of bringing down our gram-negative infection rates. And in March of last year, there was a PHE update to the mandatory database, and now for the financial year 18-19 going forward, all of this data will now be reported in a mandatory fashion. So many of you will have seen this sort of slide before. This really is looking at the total spread of infections we get within secondary care, and the purple or blue-purple colour really represents the gram-positive organisms, and some of them are listed there for you. Apologies about the small font. But the red section, which you can see is more than 50%, those are the gram-negatives. And within those, the top three are things like E. coli, which we hear a lot about, Klebsiella, and then other members of the gram-negative family, usually the Enterobacteriaceae. So this is a national data looking at the incidence of reports of gram-negative bloodstream infections through the years. And you can see, looking at the left-hand side, we've got the E. coli section there, a steady increase in the reports of E. coli bacteremia since 2009. And if you look across the other organisms, you can then, with the eye of faith, see that there perhaps has been an increase in all of them, apart from perhaps Acinetobacter and Stenotrophomonas. But again, those are very small numbers compared to E. coli. So why is all of this important? Why do we talk about this? Well, what this slide really symbolises is the organisms that you are, I presume, familiar with, things like C. diff and MRSA, which are very much part of our day-to-day work, and comparing them to other things like VRE, which is a new emerging organism in hospital infections, and of course gram-negatives. And the key thing really to point out are three important factors. First of all, gram-negative organisms, by the way that they do develop resistance very quickly. They've also got multiple resistance mechanisms compared to organisms like MRSA and VRE. With MRSA and VRE, it's really a search and destroy policy, a single organism which we're going to try and reduce, but with gram-negatives, there are so many of them, it's very difficult. When we think about attributability of infections in terms of secondary care, we really think about these organisms, MRSA, C. diff, being hospital-acquired, but gram-negatives like E. coli are very much both hospital and community-acquired. The virulence of the organisms means how pathogenic they are, how likely they are to affect vulnerable patients and cause morbidity and mortality. And again, gram-negatives are way up there compared to things like MRSA and C. diff. And importantly, whilst screening and cleaning has a role to play in terms of managing MRSA, VRE, and C. diff, that's less of an effective measure when it comes to gram-negatives. A, because these are usually the patient's own flora, and B, because they don't survive as well in the environment as things like VRE and C. diff do. So this is looking at more national data, really looking at the resistance of E. coli, which is the #1 gram-negative rod that we face in our practice, and looking at resistance rates. And you can see from this slide, as a patient has been in hospital longer, they're exposed to more antibiotics, and thus their resistance to the antibiotics that Phil was discussing, things like gentamicin, things like piperacillin tazobactam, and fluoroquinolones, like ciprofloxacin, increases over time. And there are some data at the bottom of the slide, again, which summarize that data. So if we look at work that's been published back in 2016, looking at unselected gram-negative bloodstream infection rates in England, what we tend to find is that a large proportion of those are going to be the common things that we come across: E. coli, Klebsiella, or Pseudomonas. Out of those, just over half were defined as nosocomial, and importantly, the 30-day mortality with these organisms was 15%, and that's a significant number. When we come on to think about, well, where are these organisms coming from? This data really summarizes the sorts of patients that present with these sorts of infections. And again, yes, urine is an important source. Devices and urinary catheters have a role to play. But also look at the other possibilities in terms of the sources. So, so things like the intra-abdominal sources, neutropenic sepsis, respiratory. So there is a breadth of sources that can predispose these patients to developing gram-negative bacteremias. So this is another slide really summarizing that in a bit more detail. And yes, of course, the commonest organisms that we face are going to be E. coli, as we've described. The commonest source is going to be urogenital. But then don't discount things like the hepatobiliary, things like the GI tract. But I'm fascinated with this 15% of unknown. And I think we need to keep our attention very firmly on looking at how we manage our urinary tract infections and our instrumentation of the urinary tract. But this unknown category, I think, also needs to be looked at. And again, we've got some more national reporting data, really summarizing again what I've described. The common proportion of cases were UTIs, followed by hepatobiliary, followed by other. And again, when we look at the difference between hospital and community onset, again, many more community onset cases than hospital-acquired cases. But again, the lion's share of patients presenting are with UTIs. So I'd like to thank my clinical scientist who works with me in Birmingham, Dr. Katie Hardy. These are many of her slides, which I've shamelessly pinched for this talk. And what I thought I would do is really summarize our local data in Birmingham and really try and draw some similarities between that and the national picture. So although the latest reporting strategies do not recommend we refer to our infections as pre and post, so historically we refer to our infections as pre-48 hours, those which were nominally community-acquired, and post-48 hours described as hospital-acquired, we still historically look at our data in that way, although we will be changing our reporting. But this is important in terms of demonstrating that the majority of patients that we manage with E. coli bacteremias are the ones coming through the door, not the ones that develop the infections within secondary care. The new way that we measure this data is looking at community onset who've had previous contact with healthcare systems and those who are not. And again, those patients who are naive to hospital care, those are the ones that present in the majority with E. coli bacteremias. Again, I was wondering if there was a predisposition between males and females, but overall we can see there is just about an even gender balance between men and women. And importantly for us, when we looked into our focus data, we find that there is a spread of patients presenting. So this work was done together with Dr. Hardy and one of my senior infectious control nurses, Jane Codd. They, together with help from the ICDs, went through all of the patient notes to try and identify where the focus was. And you can see that whilst the national data supports a large predisposition of urinary tract infection patients, we've got much more of a spread within our local group. But again, if you look at the purple bars, you can see we have some other, but importantly, the orange bars are the unknowns, and there's a proportion of unknown patients within each of our groups. And if we look specifically at the urinary catheter patients, what we wanted to understand was if a patient presents with a hospital-acquired or post-48-hour E. coli bacteremia, how many of those are due to urinary catheters? Well, it's interesting, when Emma was talking about the documentation in the clinical notes about the antibiotic choices, the same is true when it comes to catheterization. Sometimes patients will have intermittent catheterization, or they'll have a catheter go in because of retention and they'll have a TWOC put in, but they'll have a TWOC when the catheter comes out, but that's not very well recorded in the notes. And so the not known category is a piece of quality improvement we need to do within our own organization to understand why catheters are going in, when they're being taken out, and importantly, who's making those decisions. We will hear, and I'm sure that Elizabeth Beach will talk in much more detail about urinary tract infections and how they fit into gram-negative bacteremias, but certainly for us, we have always practiced where we tend to tie together the positive urine culture and the positive urine culture, the positive blood culture and the positive urine culture, and we certainly find there is no direct association between that. There are a proportion of patients where the urine isn't cultured, where it doesn't get to the laboratory or the wrong sample is sent, and there is a proportion also where the urine is culture negative. So we cannot say that there's a direct association between culture-proven E. coli UTIs and E. coli bacteremias. The picture, I think, is much more complicated than that. What we also looked at was longevity. So I wanted to know, for example, if a patient presents on day 0 with an E. coli bacteremia, have these patients historically had E. coli bacteremia? So are we looking at either recurrent infections or relapse of infections? And again, our data, although you would argue the numbers are small, do not support patients getting recurrent E. coli bacteremias. These appear, at least within the last 12 months, to be isolated events. So that's for the positive urine cultures, and then this is for the positive blood culture. So again, the same is true both for urine and for blood. Patients do not present with recurrent bacteremias or recurrent UTIs when we're looking at the hospital-acquired infections. So it's interesting that when we talk about all hospital-acquired infections, we like to really focus down on risk factors. And this is our own arbitrary list where we looked at, well, what risk factors do we think patients are likely to have which will predispose them to E. coli bacteremias? And again, not a large proportion of patients have predefined comorbid infections or comorbid diseases. So things like cancer, for example, things like diabetes, things like skin and soft tissue problems, none of those in our hospital appear to predispose those patients to developing E. coli bacteremias within the hospital. And then finally, just to say a few words about PHE fingertips. I presume you're familiar with the fingertip system. You're aware of how it works. You can basically go onto the website available on the internet. You can dial up either your CCG or your secondary care organization and look at your data in a bit more detail. And certainly when thinking about the numbers of antibiotics prescribed or the numbers of infections, you can get some very good data in terms of where you are as an organization compared to the England average. So I would recommend lots of examination of this website. So finally then, to finish off, I think it's in the brief I was given was, is reduction possible? I think it is, but I think it's going to be difficult as we see year on year the number of gram-negative BSIs increasing. And I think, yes, it's because hospitals are busy, yes, it's because of footfall, traffic, a population that's getting older, but in real terms, that will be an increase in the number of infections. I think that the 30-day mortality of 15% must not be ignored. I think that's a real concern, both for the NHS and for the CCG as well. So we need to think about how we're going to manage these patients, both in terms of prompt assessment, when patients present with sepsis, prompt diagnosis, appropriate safe antibiotic practice, appropriate de-escalation and stewardship, but also the longer-term follow-on care as well. And what we are certainly finding, and Phil touched on this, that we are seeing more and more patients presenting with resistant infections, both those coming in who've had frequent exposure to the healthcare, but also those who've had prior exposure within the hospital. And that then leads to more and more either broad spectrum or older fashioned antibiotics. And I think when thinking about the causes of bloodstream infections, there are some consistent findings that we have. So those patients presenting with de novo non-catheter UTIs, those who've had catheters, either long-term, short-term, urethral, suprapubic, intermittent or not, and also skin and soft tissue infections. And within the skin and soft tissue infection group, surgical site infections, I think, have a role to play in terms of E. coli bacteremias. I think it's very important that every organization focus on their underlying cause. As we've done, it's very labor intensive, but to go through each patient's notes, try and identify through an MDT process where we think the distribution is within that particular organization and focus your efforts on those. And I think in terms of UTIs in the community, we do need to focus more on that. And it's not simply a question of how we transport our urinary tract samples to the laboratory and what we give antibiotic-wise, but it's also in terms of how we manage those patients that present with recurrent symptoms. And Liz Beach will talk in more detail about the to dip or not to dip campaign. I think the prevention of nosocomial cases is absolutely crucial, because I think that when patients present from the community, there's less room in terms of managing those numbers, but certainly for the nosocomial cases, there's more that we can do in terms of being aware of the risk factors, managing antibiotics appropriately, safe catheter care. And I think, as always, there needs to be much closer working between secondary care and primary care, including GPs. And certainly when thinking about the E. coli reduction strategy and the whole health economy, we need to have, as secondary care providers, a direct line to GPs and CCG chairs to work with us to bring down the numbers for the whole community. I think the level of reduction is key, and I think the issue about delivering 50%, 20%, 10%, these are important. I think the key thing is delivering a reduction, but sustaining that reduction over time. And I think the first reductions are going to be easy, but incremental reductions year on year become progressively more difficult as there is less wiggle room, really. And we will come on to talk about this again this afternoon, but in terms of challenging behaviours, both within nursing staff, ancillary staff, and importantly medical staff, and I'm not being unkind by saying sometimes doctors are the most difficult people when it comes to changing behaviour, not just in terms of how they work, but in terms of their beliefs. You know, the standard adage that, well, I've done X for 20 years, I'll carry on. No, that can no longer work in the modern NHS. Thank you very much.